Let's talk about this marker for increased risk for cardiovascular disease, heart attacks, sudden cardiac death, development of atherosclerosis, and symptoms sufficient to justify procedures like bypass surgery or stent implantation. And there's also increased risk for stroke and disease in other arterial territories, not just the coronary or heart's arteries. So this thing is a lipoprotein, obviously by its name. It's called lipoprotein little a to distinguish it from something called apoprotein A with a capital A. That's something entirely different and unrelated. That's a particle in the HDL molecule. So lipoprotein A is an independent molecule, but it has two parts. There's an apoprotein A, that's genetically determined, and in the illustration, that's the squiggly part on the outside of the particle. And then there's an LDL particle, just like the LDL particles you measure when you do an NMR lipoprotein test, and you get an LDL particle number, not to be confused with LDL cholesterol. That's something different. LDL cholesterol is this ridiculous, outdated marker for LDL particles. Well, you and I can measure and characterize LDL particles. But it's that LDL particle you see in that illustration, that's the globular thing in the center. So that LDL particle attaches to the apoprotein A, and the combined molecule, an LDL particle with an apoprotein A, is the total molecule is called lipoprotein A. Estimates differ, but somewhere between 11 and 20% of the population has this marker that increases risk for heart disease about 200 to 300%, 2 or 3-fold. So it's a major risk factor for coronary disease, though risk can vary from individual to individual because there's great genetic variation, and there's some other factors that enter into the equation in determining whether this is going to put you in danger or not. But in general, about a 2 to 3-fold increase in cardiovascular risk. It's rarely measured by my colleagues. Why is that? Even though it's well established beyond question that lipoprotein A is indeed a major risk for cardiovascular events, significant risk, why isn't it commonly measured? Because there's no drug for it. And that's the odd, perverse beliefs of or practices of my colleagues. If there's no drug or other source of profit for some marker or some abnormality, it's ignored. And so because there's no drug, the conclusion often is there's nothing you can do about it, which is not the truth. I want to tell you what I've learned over the years, in many years of practice, cardiology, and having hundreds of patients with this genetic pattern. Some of this is borne out in the science, some of it is not. It's been borne out by many years of experience and hundreds of people with this genetic pattern. So in conventional practice, sadly, lipoprotein is typically ignored, not measured, or if it is measured, my colleagues will prescribe statin drugs and other drugs like PCSK9 inhibitors to reduce LDL cholesterol. And there may be a little bit of good in that the LDL particle is part of the lipoprotein A molecule. But no one has yet shown that those practices reduce risk. We don't have outcome data. And of course, the pharmaceutical industry is working on about half a dozen agents, many of them very costly biologics, to reduce lipoprotein A. And you can reduce it, but the question is, does it actually make you safer? And that's an unsettled question. So we're awaiting the release of pharmaceutical agents, but I wouldn't hold your breath, because here's a lesson I learned a long time ago. The most effective agent to reduce lipoprotein A is niacin, vitamin B3. And I did that for many years up till about 15 years ago when it became clear, while it does indeed reduce lipoprotein A as well as reducing small LDL particles and raise HDL and shift HDL particles to larger size, making it more effective and more protective, presumptively, it really provided no benefit. So it did reduce lipoprotein A 25-30%, sometimes more, but it seemed to provide no benefit. And that's been borne out in other clinical trials, in other settings. It's probably because niacin is a two-edged sword. While it has those beneficial effects, it also has plenty of adverse effects. It worsens insulin resistance. It raises blood glucose. It raises uric acid, which is a cardiovascular risk factor, and has some other effects that probably on balance means that niacin really provides no significant benefit. So, but let's step back for a moment and let me describe for you the typical person with lipoprotein A. The males who have lipoprotein are typically long-distance exercise fanatics. They're typically marathon runners, triathletes, long-distance swimmers, or bikers. So people with this genetic pattern oddly gravitate towards those kinds of activities. Women too, but not quite as prominently. It seems to be more expressed in the male version of it. Likewise, males with lipoprotein, oddly, this is very odd, tend to be very good at math. And so they tend to gravitate towards occupations that involve math, like mathematician, engineering, accountants, people who deal a lot with numbers, like in finance. The females, it can happen, but it's, once again, not quite as prominent. So the male expression is much more clear-cut, long-distance exercise kind of guy who likes numbers, who's very good at numbers. Also, both males and females tend to be smarter than average. Their IQs tend to be 10, maybe 20 points higher than average. So they're very smart people. They also are very tolerant to periods of deprivation, that is, water deprivation and food deprivation. So you see these people doing things like not drinking water very often going extended periods without eating. They tend to be very slender. So it might be a 5'11" guy, for instance, who's 138 pounds, or a 5'7" woman who might be 102 pounds. So they tend to be very slender, very fit, and very tolerant of deprivation, and very intelligent. Now, wait a minute here. So they have all those features, but they also have an increase in cardiovascular risk. Now, the risk, as I mentioned in the beginning, can vary greatly, anywhere from no increase in risk to extreme increase in risk, such that you could have, say, a 38-year-old woman having a heart attack, or a 42-year-old guy with a heart attack. You'll see this in families. That's one of the telltale signs, by the way. It alerts you to the possibility that lipoprotein, a genetically adverse form of lipoprotein, is in your family. If you say things like, well, my uncle had his first heart attack at age 42, and my dad died at age 51 of a heart attack, and typically, even if they're non-smokers, they tend to have early heart disease. So it can be an extravagant risk for premature cardiovascular disease. So how do you reconcile those two things? Slender, very fit, tolerance to extended periods of water and food deprivation, smart, yet very high cardiovascular risk in some forms. How do those two go? Well, think about this. If we didn't live our lives with smartphones, nice cars, and nice homes, and air-conditioned places, right? What if instead you lived out in the wild, in the jungle or forest? You'd hunt, you'd gather, right? I think lipoprotein is a survival advantage in a wild setting. So in other words, if you can run farther, if you're smarter, you can outwit your prey and other predators. You can run for hours without stopping for food or water. You make a great survivor in the wild. So where does the other part come out, the increased cardiovascular risk? Well, if you take the hundreds of people I've seen with this pattern, slender, very fit, love long-distance exercise, yet they look like they're obese when you look at their blood work. They'll have, for instance, low HDL cholesterol, high triglycerides, high VLDL, lots of small LDL, high blood glucose. It's not uncommon, for instance, for, let's say, a 5'11", 138-pound guy to be a type 2 diabetic, despite being slender and fit. So on paper, metabolically, they can be disasters. Why is this? Well, here's what I saw over many, many years of practice. So these slender, fit, intelligent people who are told to cut their saturated fat and cholesterol, eat more healthy whole grains, dietary guidelines, in the context also of a world hell-bent on consuming processed, ultra-processed garbage foods from a predatory food industry. And these people, that style of eating, that is the standard American diet, is lethal for people with lipoprotein. It's bad for all of us, right? If you eat bad food, processed food, chips, soft drinks, etc., you will get high blood glucose, small LDL, all those things that lead to diabetes, coronary disease. But in people with lipoprotein, they have it even though they're fit and slender, sometimes really skinny too. And so they seem to have an exaggerated response to the conventional ideas like cutting fat and eating more healthy whole grains. Now, what do we do about this? Well, let me tell you about a study from about 20 some years ago. So it's an old study. It's an observational study. That is just an observation in human population. So there was no intervention involved. But I think it still illustrates something peculiar about lipoprotein A. And it came from a Dr. Santika Markovina from University of Washington. And he spent some time in rural Africa, where there are two tribes of Bantus. One tribe lived on the edge of Nyassa Lake, where they fished every day and essentially had fish for breakfast, lunch, and dinner, freshwater fish for breakfast, lunch, and dinner. So a fish-based culture. A closely related group of Bantus lived further inland. This is, of course, an area that did not have cars and telephones and internet and that sort of thing. They had to walk. So it's far enough away from Nyassa Lake that they did not have a fish-based culture. They were largely vegetarian, not very successful at hunting, so they dug up roots and tubers, gathered berries, those kind of things. Now, this study group compared the lipoprotein A molecules of both, the levels and the molecules. And I should also note that these two groups of Bantus frequently intermarried, so there's a lot of genetic overlap between these two groups. And both groups had high lipoprotein A levels, blood levels. But the interesting thing was the apoprotein A component of the lipoprotein A was much lower, almost half, in the fish-eating Bantus compared to the non-fish-eating Bantus. Now, judging from that, based on that, this is many years ago, I asked patients with lipoprotein A to supplement 6,000 milligrams of EPA and DHA from fish oil, because the fish-eating Bantus were estimated taking as much as 5,000 milligrams of EPA and DHA per day, so a fairly hefty dose. To stack the odds in favor of a positive response, I asked patients with lipoprotein A, these slender, fit, intelligent people, to increase their omega-3 fatty acid intake from our usual 3,600 milligrams of EPA and DHA to 6,000 milligrams of EPA and DHA. And important to note, not 6,000 milligrams of fish oil, 6,000 milligrams of EPA and DHA contained within the fish oil. In order to do that, you have to choose very high potency preparations. For instance, if you took a fish oil off the shelf at most stores, one capsule will typically contain 180 milligrams of EPA, 120 milligrams of DHA, 300 milligrams total, right? 180, 120. You'd have to take 20 capsules per day. Impractical, right? So if you got a high potency preparation, for instance, there are some capsules that have 1,000 to 1,200 milligrams of EPA and DHA. You'd have to take, 6 or something like that. Or you could take liquid fish oil, a little more expensive, but a very easy way to get this high dose. Well, it did not reduce lipoprotein A significantly. What it did, though, was it helped shift the LDL particle to a large LDL particle. So recall that LDL particle. That component of the lipoprotein A can be large and benign or small and very, we say, atherogenic, likely to cause heart disease. Well, that LDL particle that's in the lipoprotein A influences the behavior of the lipoprotein A molecule. We therefore want the LDL particles all to be large and benign. So the primary goal I found with lipoprotein A is to not reduce lipoprotein A. It's to get rid of, minimize small LDL particles such that the LDL particle component of the lipoprotein was large. And what I saw by doing that was that we arrested or stopped the progression of carotid and coronary disease. So in general, my programs where we go wheat and grain free, no processed foods, that lower dose of omega-3 fatty acids, magnesium, iodine, vitamin D, things missing in modern life that, when put together, minimize insulin resistance and inflammation, and then we address the microbiome. So what I saw in people with lipoprotein A taking this higher dose of omega-3s did not reduce lipoprotein A, but it helped get rid or minimize small LDL particles, and that seemed to put a stop to coronary disease progression. Other people achieved regression. So if we're following, for instance, coronary calcium scores, and somebody had a score, say, 400, which is kind of high, they do this, and then a year or two later, a score would be typically 270, something like that. We got regression of plaque as judged by this coronary calcium measure. And you, by the way, when you do a CT heart scan, you can see the softer elements. You can't quantify them like you can calcium, but you can see them, and you can see the plaque had shrunk. In lipoprotein A people, I see that you don't achieve regression, you just achieve stabilization, or you halt progression, which is still very, very important. So there's clearly something unique, right? There's that we don't know about. Perhaps we can go further, but I don't know what that is yet. But at the very least, high-dose omega-3 fatty acids has proven to be very important. We've not done a prospective study where we did high-dose omega-3 versus standard dose or placebo. We've not done that. It's very expensive to do that. We'll probably never do that. But I can tell you from having done this hundreds of times, high-dose EPA-DHA at a dose of about 6,000 milligrams per day has helped a lot in these lipoprotein A people, and the vast majority, with rare exceptions, the vast majority stop the progression of their coronary disease and their carotid disease. So if you want to have your lipoprotein A measured, you have to specify it. Ideally, it's one of the tests that yields measurements in nanomoles per liter, particle count per volume, and not milligrams per deciliter, which is weight per volume, because the particle size can vary widely in size and weight. If you just measure weight, you don't know anything about the number of particles. And it's the number of particles that matters more, because the more particles you have, the greater potential there is for interaction with the walls of arteries to cause atherosclerotic plaque. So you really want that nanomole per liter measurement, that is particle count per volume. Now, the methods used are kind of complicated, multi-step processes. So if you try to find out what method is used, or you ask your doctor, he or she won't know. Okay. So what you have to do is go to the lab you're interested in and try to get a sample result. Can you show me a sample result of lipoprotein A? And if it's in milligrams per deciliter, move on. Try another laboratory that will give you the result in nanomoles per liter. If you have it in milligrams per deciliter, it's not the end of the world. It's just not quite as accurate. And in nanomoles per liter, we're aiming for 75 nanomoles per liter or more. That suggests higher risk. And in milligrams per deciliter, 30 milligrams per deciliter or more. Can you convert the two? Not really, because the particle size is so variable, you really can't convert weight to particle count reliably. So ideally, you get a laboratory that measures your lipoprotein in nanomoles per liter, and then do my programs. Because my programs go by a variety of names. Could be called Super Gut, could be called Wheat Belly, but I could have called it the program to eradicate or minimize the expression of small LDL particles. That's not very appealing though, right? But that's what the program achieves. We do that because we eliminate wheat, grains, and sugars. Those provoke formation of small LDL particles. We correct magnesium, iodine, vitamin D, and omega-3 fatty acid, lack of those 4 components, when put together, minimizes insulin resistance and inflammation, thereby adds to reduction in small LDL. Then we address bowel flora, dysbiosis that virtually everybody has. We do that with a variety of methods, right? And then that also reduces the contribution of endotoxemia, that is, toxic breakdown products of bacteria in your small intestine, more so than the colon, that contributes to insulin resistance and inflammation. And by the way, insulin resistance and inflammation, major drivers of diseases, including heart disease, coronary disease, but even more so in people with lipoprotein A. So once again, slender, fit people, right, who love to run or swim or bike long distances, yet they look like they're obese. So they are much more susceptible to the effects of insulin resistance and inflammation. So the basic program, diet, supplements, address the microbiome, and with the one tweak being higher doses of omega-3 fatty acids. Now, if you learned something from this YouTube video, I invite you to see my other videos, my Defiant Health podcast, my thousands of blog posts on williamdavismd.com, or if you want to have conversations about this, two-way conversations, I invite you to join my conversations in my innercircle.drdavisinfinitehealth.com.